We're going to go ahead and get started. We want to warmly welcome everybody to our session today on optimizing cardiac ICU resource utilization and patient safety. This is going to be led by a team of experts on nurse-driven care team collaborations. I am your host today, Dr. Helen Marie Merritt. I practice out of Methodist Physician Clinic here in Omaha, Nebraska, and it is my pleasure to introduce you to our panelists today. Our first panelist is Cami, who is an internationally renowned speaker. She's been all over the globe with over 45 years of clinical and critical care experience. She has taught the CCRN exam review as well as critical care updates with an emphasis on critical care thinking for the bedside provider. In addition to lecturing across the world, she's a reviewer for several renowned nursing journals and has numerous publications. She continues to have an active practice at the University of Florida within the Critical Care Division and Cardiothoracic Surgery. She brings many clinical practice skills to her lectures as well as providing pearls for the bedside provider. Next, we have Minnie, who is a former colleague of mine from the University of Nebraska Medical Center and a current friend. She is an excellent nurse who has a ton of bedside experience in the cardiothoracic ICU and our progressive care unit. She's been a clinical educator and recently took over as the program coordinator for the BAD program within our institution. Lastly, we have Vicki, who is the Director of Clinical and Quality Outcomes at Providence Anesthesiology Associations in Charlotte, North Carolina. She has been responsible for the implementation, oversight, and expansion of their ERAS program, which includes 9 facilities and over 17 service lines. She's spoken nationally and internationally on this topic and has clinical areas of interest, including multimodal analgesia, reduction in opioid consumption, and postoperative cognitive disorder. She worked as a critical care nurse for over 15 years before leaving the bedside to pursue her advanced degrees. So next we're going to have a poll to kind of get our juices going about this topic. You should be able to see it now. What are your cardiac surgery program's top 4 challenges or areas of focus? So pick up to 4 different options here. There's caseload volume with patients' reluctance to come to the hospital, especially in a pandemic, adequate staffing or understaffing, again, especially in our current times, staff safety and long-term exposure, staff stress, patient safety, ICU resource allocation, facility financial constraints, and uncertain future constraints. We've still got several people chiming in, so get your answers in. We'll wait a couple more seconds here. All right, so you should be able to see our results now. It looks like staff stress is at the top of the list for many of our attendees, followed by adequate staffing, which probably relates to the above, and then ICU resource allocation coming in here. So with that in mind, it's a nice segue to our first discussion, and I'll turn it over to Cami for that.
Good morning, everybody. Good morning. Well, I'm trying to share my slides. There we go. Good morning. Good morning. As you can see, oops, sorry, 1 second. There we go. Good morning, everybody. Good morning. The topic for today, and thank you so much for joining us for this quick webinar, especially at times when we're all very stressed. We can see by that poll. The topic today is strategies for the nurse at the bedside, for the administration, for whoever cares for the patient to look at and try to really take care of patients with resources. I keep getting the poll that keeps coming up. Sorry. Liberation, that's what we're talking about today. And the definition of liberation is the act of setting someone free of imprisonment, slavery, or oppression or release. But I'd like to think of liberation, especially today in today's world, is liberation is the freedom from limits on thought and behavior. And that's what we're all working with. Now, resource allocation is not something new. The COVID crisis did not bring this out. It happened many years before. I think we've all had some drug shortages, bed shortages, equipment shortages. We've all gone through stages with that. But this crisis has really led us to huge problems with ventilators, with beds, with not allowing elective surgeries, and like you said, with patients not being able to come to the hospital as freely as they wish. So I'd like to talk a little bit about the Liberation Bundle, and this is a collaborative protocol that was started many years ago, probably around 2010 is when it really started, with the Society of Critical Care Medicine and AACN, American Association of Critical Care Nurses. Our goal in trying to provide this was the patient who couldn't get off the ventilator, a patient who is just languishing and not improving despite what we do for them. So this bundle was to reduce ICU complications and improve the outcomes, especially of people who have prolonged intubation. So it started off as the ABC bundle, then it became the ABCDEF bundle, and now it is called the Liberation Bundle, which includes the PADIS program. So A is assessment, prevention, and management of pain, which we think we do pretty well. However, the research shows that maybe one of the causes of delirium that we see with patients with prolonged intubation could be inadequate pain control. And I think everybody uses a pain assessment scale, but sometimes that's very difficult to use on the sedated, prolonged intubated patient. B is probably one of the most important things that we really started right around 2015 in earnest, to provide both spontaneous awakening trials. Well, that's not really new. If you have a patient that is being sedated, every shift you have to reduce that sedation, wake up, and have the patient do a neuro exam to make sure that neurologically they're okay. So that has been good. And if the patient is successful, has a good awakening trial, our real goal is to reduce the sedation. If they can do a successful awake trial, then the next thing is a spontaneous breathing trial. And even with pretty moderate ventilator management, you can wake this patient up and let their diaphragm begin to work. Physical therapy has been wonderful in teaching us at the bedside that the diaphragm begins to get atrophied only with 2 hours on a ventilator. So imagine being on the ventilator for 5 days and someone comes in and looks at the patient and says, oh, they're great, just extubate them. And their poor diaphragm cannot withstand that workload. C is the choice of analgesia and sedation, which should be very short acting. That's why a lot of us like Presidex or the very short acting drugs. Turn it on, turn it off, the patient wakes up. Delirium is a big problem. It's a very big problem, especially in those people who are on a mechanical ventilator with sedation greater than 5 days. And that is what we're seeing right now with the crisis. So understanding having a delirium scale and agitation scale. Early mobilization and exercise is important for the diaphragm, the lung, the brain, the kidneys, the heart, the whole person. We have patients now on VA ECMO that are centrally cannulated that we get up even on a ventilator and walking or using an exercise bike. I know it sounds crazy, but we do it, and we do it carefully with a collaborative approach and are very successful. The last part is family engagement and empowerment. And I think this is something that is very difficult today because most of us are under the problem of only one visitor can visit the patient in the ICU for the entire stay. This puts so much stress on the family, and that stress is compounded with the nurse. Right. So let me tell you a little bit about University of Florida. That's where I work. I'm an NP in the CVICU, have been there for many, many years. I hate to tell you, over 30 years. And I have seen some dramatic changes. We now have intensivists. We now have protocols. We have 24-hour coverage. But around 2012, when I was still working, some of you may not have even been born then, 2012, we had a dilemma. We had patients coming out of the OR, maybe at 9 o'clock at night, maybe at 10 o'clock at night. And yeah, they were sick, but they were the third case, and they wouldn't get extubated until the day shift came back on in the morning. Oh, let's just wait overnight, keep everything stable. Now, we did have an advanced practice provider at night, but 10 and 15 years ago, that one provider at night, 7 p.m. to 7 a.m., took care of the 24 ICU patients, the floor patients, went to every code in the building, and had to cover the emergency department for thoracic surgery. That's a huge problem because that provider may not even be in the ICU when you're trying to extubate. So Dr. Brian Gelfand, who's a lovely, lovely man, he's an intensivist, a board certified surgeon, board certified anesthesiologist, and critical care medicine, who now unfortunately left University of Florida, is at Vanderbilt. He said, we need to change our practice, our model of care, and we need to provide the nurse at the bedside and the RT at the bedside a mechanism, a methodology to get these people extubated, even if the APP is not present. Now, just to give you a little feedback or a little understanding, this is an x-ray of one of our pre-op patients. We don't usually have in our 24-bed unit a simple coronary with a normal EF, a valve, maybe heart failure, maybe a double valve. No, we have a patient like this who has COPD, emphysema, diabetes, hypertension, has every comorbidity, and a 10-centimeter ascending aortic aneurysm. Now, this patient had been an elective surgery. Now, we had to stop elective surgeries. Now we are beginning to do it, but she came in with pain and that needed surgery. So a very difficult person. This is another person post-operatively, not the same person, but you can see this aortic stenting, and she's got a defibrillator, and she's a little tiny lady. We have very complicated patients. And even if you're in private practice, the normal coronary is just not there anymore. It's a normal coronary, just a 4 or 5 vessel coronary in a 80-year-old who has diabetes, hypertension, COPD, multiple allergies, multiple other problems, and has already had 2 surgeries. So we see complicated patients. With today's crisis, look at what the nurse sees. And then you see on this side, this is actually me in the middle. I'm the shortest person always. We are ready to admit a patient, double masks, lots of equipment. And now with the COVID crisis, about 5% of all patients will develop, of all the patients who turn positive, will develop acute respiratory failure. And of those patients, 90% will require prolonged intubation mechanical ventilation. So many of us do have what we need. However, we are in short supply. About 2 weeks ago, we had a patient in the unit, 30 years old, who really did badly. Is arresting, we're doing CPR. The surgeon wanted to put him on ECMO. We didn't have any ECMO pumps left. We had 24 ECMO patients already on full support, and he wanted to do it. So we had to quickly put together a centromag and an oxygenator. It did take some time while we're doing CPR to cannulate the patient at the bedside. So many of us don't have what we need, so we must act very quickly and with great care to utilize the science that has proven our protocols and our guidelines. Now, I know this is hard to see, but you're going to be able to download this sometime during this program or after, because about 2012, Dr. Gelfand and the whole staff developed a daily wake up plus protocol. And the plus was breathing to extubate spontaneous trial. And I know you can't read it, but up here in the very first part of the trial, and this empowered the nurse and the respiratory therapist at the bedside to begin the weaning and do the best without an order, because it was embedded in the post-op orders. So safety, is the patient really neurologically? What are all their parameters? If they pass this, then start beginning the sedation decrease, and keep a RAS of 0 to -1. So it gave the nurse and the respiratory therapist great parameters of what they could do, and then verify that they could spontaneously breathe. They weren't relying on the ventilator, so that anesthesia was wearing off and they were awake and alert. Then they had to pass another little exam here. Alrighty,
Hey,
just
Tammy,
the weaning.
I'm so sorry to interrupt. We still can't see your slides, actually. You're doing a fantastic job, but I know there are some really important
Oh
points that
gosh.
people are hoping that we can share. If we can't get it to work, we will be sure to share these slides at the end.
Okay, let me, I have sharing. Oh, I am so sorry, everybody, because the slides are so good. Oh, I can see me. Now I say share screen.
And Catherine's telling us share screen, choose the slide, and then hit share again.
Choose the slide and share again. Oh dear.
We can keep troubleshooting too.
Okay,
And like I said,
I will.
we can share at the end too.
Okay, I'll just try to continue, because you will be, all the participants will be able to have a copy of the slides, especially of this protocol that we're talking about right now. It's a very well-developed protocol. We started 2012. It really came into being about 2014 with the Liberation Protocol, but it gives the nurse and the respiratory therapist, it's like the ACLS protocol. On one side, you have your protocol. If they pass, move to the next. If they don't pass, move over, and we have to back up again. So at the very bottom, it goes to weaning parameters and extubate. So the nurse themselves, the nurse and the RT, could extubate the patient without a direct order and without APP or the surgeon or the intensivist being in the room. Oh, I'm so sorry you can't see these slides. The next one is, now we were doing very well, and the goal in the beginning of this protocol was to get people extubated within 4 to 6 hours. And as we were learning more and more, you know, there are patients that are not going to be extubated early. They're too ill, they have too many cardiac problems, they have too many respiratory problems, they're not going to be extubated. So what we then did is what we call the fast-track extubation weaning protocol, which is on every post-op order. So the nurse does not need an order to start weaning the vent. So the first part of this is weaning the vent, weaning the ventilator, and then how is the patient responding to that? So the first thing, patient weaning criteria, is their hemodynamic status. If they had a cardiac index of 1.7 and they're bleeding and acidotic, that is not a patient to wean. So they have very strict criteria to follow. And then if everything is going well and they're passing, and it may not be between the 4 and 6 hour window that we wanted, maybe it's 8 hours, but they're progressing. Stage 2 is really start weaning that ventilator. And then extubation criteria. I wish you could see this. The extubation criteria include, what's the neurologic state? And for years, we thought if the patient could pick their head up off the pillow, they could be extubated. We know that neck strength has no correlation to diaphragmatic information. So neurologic state, complex commands, moving everything. And unfortunately, where I work, and I'm sure where you work, sometimes your patient during surgery has a stroke or after has a stroke. So good neuro exam, their labs, what's their sodium, their H&H. If they have a gag reflex present, and the presence of secretions. With our patients with COVID, with our patients with prolonged intubation, what happens sometimes is the reason we can extubate is their secretion burden. Maybe we're doing bronchs, maybe their secretions are very thick, and we do all of our interventions to make that better, but sometimes we can't extubate because of secretions. What are their vital signs? PF ratio is very important. When I write an extubation note after the patient or right before the patient is extubated, I have to include the PF ratio. PF ratio is a very good index of will the patient be able to be extubated and how much oxygen they may require with extubation. Since we're aiming for earlier extubation, sometimes we use high flow oxygen, high flow nasal cannula when the patient gets extubated. And you know that works so beautifully for these patients. And all the research and what we've seen in our clinical practice is that we can extubate a little early. Maybe, it's not iffy. The patient meets the criteria, but, they're still on 50%, or they still need a little pressure support. That high flow works well. The presence of, if they had sleep apnea before, their NG tube, what kind of airway did they have? We now have a lot of little tiny women that have very difficult airways, or sometimes very obese people that had a very difficult airway. And we know that by looking at the anesthesia record. That was a difficult airway. If they don't have a cuff leak, we might do some other parameters before we extubate. So a lot of different parameters. And when we finished doing this about 2016, 2017, we were making great progress. We were able to utilize resources well, and the resource is not the ventilator. The resource is the bedside nurse and the respiratory therapist working together collaboratively to go through a protocol, very well written. And that protocol was written by nurses, by RTs, by APPs, by the intensivist, by the surgeon. That was a feat just to get everybody to agree. In the beginning data, it took us on average of extubating people 12 hours. Now, 80% of our patients are within a goal. Now that goal is patient specific and not just by the clock. So everybody asks me, how do you make all these changes? Changes, nobody likes to make changes, but the one thing you can take home every day is that change is always going to be present. Every day a new protocol, every day a new thing about sepsis. So fundamentally, we had to reset the care ratios in the ICU. So one of the first things that we were able to accomplish is getting an RT staff that only works in our unit. Now, can we always have the same one? No, because people come and go, but the essential group of people, number one, they love cardiac surgery, they love our unit, they want to work there, and they have a very refined protocol there. Establish the accountability, have a definite plan based on the patient, not the clock. Again, this is patient-centered. Give responsibility to the nurse and the respiratory therapist. But the bottom line, the best thing that made this work is that our group of multi-professionals gave the authority to the nurse and the respiratory therapist that, yes, you can do this. You don't need a direct order. You don't need me by the bedside. You can make the decision. You are well educated. You understand the protocol. You're working as a team. If one of the team members says, I think we better wait, you call for a consultation, right, with your APP or the intensivist. So they had accountability, responsibility, and authority. This really changed our model of care. Instead of having, that pyramid of care, we now have sort of a nice leveled care protocol, which really generally empowered everyone taking care of that patient to present and express their thoughts on the patient care. So we became a true patient-centric model with a level of team care. So this created a fast-track extubation. Again, was not for the normal person. These were our goals for people who are difficult to extubate. So we're all on the same page, all on the same goal. We want to get this patient. It might be 3 days they're intubated, but what are we doing to progress the patient? Are we still keeping them terribly sedated? They barely wake up. They're not managing their awake trials. Do we get a CT of the head? Did we find out why they're neurologically not awake? To move patients forward. And it's been refined over time. Our protocols always change for the better. Education is the key to success and the key to survival always. But the real deal at the bottom of this huge change we made in patient care, we had improved physician, improved APP, nurse and respiratory therapy satisfaction. So today we're so worried, you already showed in your poll, we're so worried about the stresses that nurses and RTs and physical therapists have. Now we have something that we can actually give the nurse at the bedside, the respiratory therapist, accountability and authority to provide the care that they're trained to provide. So the bottom line is that patient outcome was very improved. I wish you could see this slide, and hopefully you will be able to later. This is a patient that we had in the ICU 7 days on event, finally got her extubated. It's the 4th of July, all this going on. And what we did, we got her a pair of sunglasses that were red, white, and blue. She's smiling, she's happy. And I know you can't see it, but her nasal cannula is off. She's on room air. So we acknowledge the current challenges that interfere with comprehension or comprehensive management of critically ill patients during this pandemic. We all are suffering under this. Rapid response to new circumstances, however, of critically ill patients requires established safety mechanisms, protocols, improvement of protocols, and the Liberation Bundle. The Liberation Bundle has been proven globally to be very successful to get people off ventilators and to help survivors maximize recovery as early as possible. So to move outside the normal, to move toward passionate creativity, to provide compassionate care is to liberate. My last slide I wish you could see is a turtle swimming in the ocean. Knowing is not enough. We must apply. Willing is not enough. We must do. This was written many years ago by a German philosopher, but the person who used that sentence the most was Eleanor Roosevelt. Thank you very much. I'm sure we'll have time for questions at the end, and we'll make sure everybody is able to get those handouts. I'm so sorry. Thank you, everybody.
Thanks so much, Cammie. We certainly value your expertise and your ability to keep on going even with technical trouble. We're all learning here. Next up, we're going to have Minnie. We'll keep working on getting those slides to you guys. Thanks for bearing with us on that. Minnie's going to talk to us about strategic implementation of new strategies. Minnie, go ahead.
Okay. Are you able to see my slides?
Yes.
Great. Well, I just am honored to be here with the other renowned panelists, and thank you for having us today. My name is Minnie Flourish, and today I'm presenting on Nebraska Medicine's strategic approach of how to implement new technology, specifically how we used FMEA, or failure mode and effects analysis, to integrate the active clearance system for our cardiac surgery patients. And I'd be remiss without mentioning my colleagues who are integral in this part, this particular success story. So special thanks to Dr. Merritt, Michaela Newman, and Nikki Scriven. Nebraska Medicine scenario is not unique. Cardiac surgery patients everywhere have chest tubes put in to facilitate drainage from their operative procedures. So the traditional method of managing chest tube patency is called milking and stripping the chest tube. This milking or stripping is a manual manipulation of the tube in order to promote drainage to prevent serious complications such as cardiac tamponade. So there are several studies that show that there are risks of negative outcomes associated with this practice, including tissue damage, increased bleeding, and left ventricular dysfunction. So because of this, many organizations don't encourage this practice anymore. Providers at Nebraska Medicine had heard about a new product that negated the need for traditional methods of clearing chest tubes. But since it was a new product and hadn't been utilized here before, it was decided that an FMEA would be beneficial. Some of you might be aware of ERAS, or Enhanced Recovery After Surgery. For those that are not, a simplified explanation of the purpose of ERAS is to develop a set of evidence-based perioperative protocols to support patient outcomes. So I thought it was important to note that as of 2019, Cardiac Society ERAS recommends against the practice of milking and stripping to achieve chest tube patency, as well as breaking the sterile field to remove clots. The Nebraska Medicine UNMC organization values innovation in improving outcomes for patients. So therefore, the cardiovascular leadership felt really strongly about pursuing this new technology because the published clinical data on the active clearance system had positive results. So of note, Nebraska Medicine brought this product in-house in 2018, prior to the 2019 Cardiac Society ERAS guidelines coming out. So our service line was courageously striving for excellence as well as innovation. I thought it might be helpful to give some insight into how this product works for people who are not familiar with the system. So this video demonstrates how the active clearance system works. The system inserts between the chest tube and the drain tube. There's a clearance wire and loop inside the system's guide tube. It's advanced and retracted within the chest tube to remove clot and keep the chest tube patent. The internal wire clears the chest tube and prevents the retention of blood and fluids in the chest cavity, and this elimination of accumulated blood and fluid in the patient's chest reduced the occurrence of retained blood syndrome complications, as well as preventing breaking sterility and decreased the need to milk and strip in order to clear a clogged tube. So it's easy to keep the visible part of a chest tube patent. You can see in the bottom left picture, most of the clotting occurred in part of the chest tube that rests inside the thoracic cavity. So this is why this active clearance device is so beneficial. The wire can assist with clearing this part of the chest tube, the part that the nurses or surgeons cannot visualize because it's inside the patient. So as we all know, successful implementation of changes to care processes and introducing new equipment requires extensive planning and preparation. So because of that, Nebraska Medicine uses the FMEA process to improve our implementation of change at the bedside. So to provide a little more background on FMEA, it's a method that enables evaluation of a process, new or old, to identify if and where that process might fail, and also helps in assessing that potential implications for those failure modes. This is the team we worked with to complete the failure mode and effects analysis to assess for risk versus benefit in using this new product. So as you can see, we had strong leadership support, including our cardiovascular service line director, a wonderful physician champion, and quality department representation. The rest of the team members were identified by this leadership team and included CT surgery team representatives who would be present in the OR and also in post-surgical care. We had representation from the OR surgical staff team, the nursing clinical educators, or as we call them, nursing professional development specialists of all 3 inpatient units who care for post-surgical cardiac patients, and finally the Pluriflow vendor. I apologize for this slide. You don't have to be able to read the tiny print. Its purpose is to provide visual context to our team's process. So the first thing that our team did was map out step by step on how to use this product. There were a total of 29 steps evaluated, and the team worked with the vendor to create a process map based on the IFU and unique needs of patients and staff here at Nebraska Medicine. So we identified everything from where the product would be located and who would be responsible for each step. We discussed individuals involved in the use and identified which process steps were appropriate for each role to ensure staff were not operating outside of their scope. So once the team identified the process for how to use the product, the FMEA team identified potential failure modes within the process and then ranked each failure mode by severity, occurrence rate, and then the ability to detect. A risk prioritization number, or RPN, was then calculated for each of the potential failure modes. So we focused on the process steps that had high RPNs as process steps that we should highlight for staff education. So one of the process steps that ranked with a high RPN was cutting the Pluriflow chest tube precisely where indicated. This step ensures that the chest tube length is appropriate so that internal wire used for actuation cannot exceed the tube. So this was a major discussion point for the team as to what the OR support team's education and training would focus on, since cutting the Pluriflow chest tube only occurs prior to the chest tube insertion. So by using the FMEA process, we were able to pinpoint key education items. Another benefit of the FMEA process was identifying the key stakeholders in the care of our post-surgical patients. Not only do we have to educate the nurses and our patient care techs who work on the inpatient cardiac units, we identified PT, OT, cardiac rehab, and radiology as members of our team who would need to be aware of this new device. This sign was used to identify patients as having a Pluriflow chest tube for the various care providers. While walking through the proposed process, staff identified that the IFU, or instructions for use, recommended clearing schedule was not realistic in all settings that these products will be used in at Nebraska Medicine. So the team worked with the vendor to investigate the reasoning behind the schedule listed and what other hospitals had found to work. Our key takeaway for our team was to ensure that our policy that we put into place truly reflected what was going to be practiced. The team also identified that the current charting options wouldn't allow nursing staff to document the times that they were actually clearing the device. So team members worked to update our electronic health record to include the intervention of actuated into our flow sheet. So as with all devices and protocols we use, application is determined by clinical context. So in this case, while the vendor provided a recommended actuation schedule, it's recognized that the clinical context may require deviation from this recommendation. To determine an alternative actuation schedule might be suitable to our situation, we conducted 2 trials. We compared the recommended schedule with a protocol developed by our own team, and then we reported out on the outcomes of both trials to Nebraska Medicine's Risk Council, who approved our proposed schedule. So we were able to successfully roll out the proposed schedule change to all the inpatient cardiac units and place this guidance into our CT surgery team's order sets to guide nursing practice. So as you can see, we found many benefits of using the FMEA process to introduce a practice change and new equipment to our institution. As for outcomes and what's changed, there is consistent data from the company that shows positive results with significant outcomes, and this can now be considered the new standard practice for clearing chest tubes.
Thanks, Minnie, and a huge shout out for you guys for continuing to push this forward. I often joke that it took me longer to grow a baby than it did to get the system approved. So they kept working really hard while I was out on leave and, you know, explored areas that haven't been there before. There was a quick question from the audience from Dr. Cooley, who was asking if we've seen any problems with not clearing the chest tube as the indication is for every 1 hour. And I know it's been kind of standard up on our CPCU to do every 4 hours.
Yeah, we haven't had any poor outcomes at all, and we actually were taking pictures of all the chest tubes upon removal to kind of look at what the internal chest tube looked like, and there was no clotting following our actuation schedule. And actually, in the ICU particularly, we actuated more often than the IFU recommended if we had somebody who was bleeding, but following our unique protocol to Nebraska Medicine, we had very good outcomes so far.
Great, thanks. We're gonna have some time for more questions at the end. We're gonna go to Vicki now, who's gonna talk us through how to appropriately implement an ERAS protocol within your team at your institution. Vicki.
Hi everybody. Thank you so much, and thank you for having me on this webinar. Very much appreciate the opportunity. I'm coming to you from Charlotte, North Carolina, my only disclosure is my involvement with the ERAS Cardiac Society. So I'm going to put this up there right now because I only have a few minutes to go through this, and talking about a successful implementation and team building really could be an all-day event. So we published this earlier this year, a guide to team building and successful implementation. So everything that I'm telling you goes into more depth in this publication. This was up on the screen in the last presentation, the guidelines for perioperative care and cardiac surgery. Great resource. It's a great place to start. There's a lot of literature out there on ERAS for cardiac surgery, and a lot more emerging all the time. So really take a look at the evidence that's out there. So essential steps for successful implementation. These are steps that really you can't skip any of them. If you think that this is going to be a very quick process and you can jump around and omit steps, you're going to doom yourself for failure. So first step that you need to do, assess the current status. What is working in your program and what is not? And what do you want to change, and why do you want to change it? Are you not practicing the most recent evidence-based information, or do you have high AKI rates? What's your STS data looking like? So really look at that status. Go to your data, your current data, and pull length of stay, pull the financials of it, complication rates, and see where you need to really hone in. Because if you have an area that's working well and it's evidence-based, don't try to reinvent the wheel with that. So communicating that case for change is very, very important. Everybody needs to hear the same message. Everybody needs to hear the why behind it, from hospital leadership down to, physical therapy, nutritionists, nursing. Everybody needs to hear this. And it's important to have the right people communicating the case for change. People who can answer the questions, who can have the discussions, and really be the motivators to start this change. Because you have to remember, it's not just about changing your practice, you're changing a culture. This is complete change management. Team building, which we'll get into in just a moment. Protocol development. This takes quite a long time. Everybody has their own process. For us, typically I go and do a very thorough lit search, pull as much literature as I possibly can, read it all, bring it to the table, typically with just a few people to get started, and write what I think is going to be an appropriate protocol. That protocol is then discussed amongst the team, and we throw ideas around, we talk to other programs, and then we build our protocol. Understanding that a protocol could potentially be fluid. I call it cardiac ERAS 1.0 and cardiac ERAS 2.0. There will be several iterations. So once you start your pathway, you may find that something doesn't work quite right, and it's okay to go back and make those adjustments. Planning of the implementation is key to understand your timelines. When you're starting out and you want to maybe pick a date, a roundabout date of implementation, it's important to stay on track and to have your plan set out. I follow a checklist, which is published in that paper. I work by checklists. So using a checklist, a flow map, anything you need to use to make sure that you have a plan and you're following that plan. Patient education, start that early. You have to understand, if you have to print certain materials, you need to start on that very early. Team member education, also needing to start on that early, developing it, who's going to do it, when are you going to do it? Ideally, you want to do team member education only a few weeks out from your implementation, so that you're not educating and then you implement a month or two later and everybody has forgotten. And then data, again, like I said before, the pre-data and the after data, you have to audit your program. If you don't audit your program, you don't know if you're succeeding. And not just the patient outcomes, which are very important, but also the compliance or the process outcomes. If you find that your protocol isn't working, your outcomes are not where they should be, is it a pathway issue or protocol issue, or is it a compliance issue? Ideally, you want to have at least 80% compliance for your program to be successful. And we measure compliance in all phases of care and in the providers that are a part of the patient care. So the IHI, you've probably heard of the triple aim, looking at better outcomes, lower costs, and inpatient experience being the three of the triple aim. And now they've added the fourth, so the quadruple aim, also including the provider satisfaction, team member satisfaction. And I talk to team members all the time about this because it is a huge undertaking and it is a lot of change. And sometimes the nurses especially will look at me and think, are you crazy? And I tell them, your patients will do better. I promise you, it will actually make your job easier and more enjoyable. And every time we implement a new pathway, that's exactly what they come back and say. So team building, really quickly, typically starts with a surgeon, anesthesiologist, a nurse, nurse coordinator or ERAS coordinator, an APP perhaps, just to start off and get the information up front that you need to have. But then your team is going to grow. You'll want to include a CRNA. A hospital leadership is very important. Somebody from the pre-anesthesia testing clinic or wellness clinic, if you have one, pharmacy, dietary, PT, OT, cardiac rehab, or if you're going to do cardiac prehab, who's going to be a part of that? Your IT department, so that you can build order sets, and an analytics team, a QI department person who actually does the data. Everybody knows this, right? Working together, synergy is better than working alone. You cannot do this alone. This is not a one man or one woman show. It has to be the team, and the team has to work well together. They need to be respectful of one another. They need to listen. They need to be able to communicate with one another and freely and have their ideas heard. They need to have the same goals. Everybody needs to be on the same page at all times. Very important for everybody to work together on this. We meet every month, our team does. When we're starting out a pathway, we may be meeting every week or every other week, but then we go to every month once we implement. Same date and time every month. So part of your team is going to be who's going to lead that team. And it's helpful to have two leaders, actually. Somebody that's in hospital leadership that can really get things done that need to get done. They can work with the capital equipment team. They can work with the finance department. They can work with high-level IT to get order sets built, what have you. But helpful to have that hospital administrator. And then a nurse or a coordinator or APP, somebody that's boots on the ground, can make sure that all of the boxes are getting checked. Everybody's doing what they are supposed to be doing, involved in education, all of that. So the team itself works together, but it's helpful to have those dotted lines to the two leaders, because if you do meet, every other week or once a month or whatever that is, things need to be happening in the background in between those meetings. So very important to designate leaders, and these people have to be individuals who are going to get things done. They have to be able to provide results. If you find that you have team members that are not producing results, or they're not following through on their commitments, you need to take a look at that and revise your team. We've had to do that a couple of times. Our program's been going for 4 years, so we do probably yearly look at our team list, and we do have to revise sometimes. We want to just stay calm, get things done. It is very hectic to implement these programs, but you just have to know that if you follow a checklist or follow a plan, you will be successful. And when you implement, you have to celebrate. When you have those first few patients going through, it's very important to come back to the staff to celebrate the wins, show the data so that everybody who's involved understands what their efforts are actually doing, and celebrate the program. A few resources here for you. Of course, the ERAS Cardiac Society is a big one. The ERAS Society, EPOM, and Top Med Talk is a great podcast. They've got a ton of podcasts on a whole host of things. POCI, Perioperative Quality Initiative, they have consensus statements on their website, great consensus statements, and ACER. I encourage you, if you are starting a program, or even if you have one and you haven't checked out these resources, to please do so. I thank you so much.
Thanks, Vicki. Great talk. I have a couple questions coming in, and then we're going to have one more poll. One of the questions really relates to all of you guys, whether it's ambulating someone on VA ECMO, or trying to get a new active clearance technology in, or implementing a brand new ERAS protocol. So the question is, how do you usually handle resistance to new ideas and compliance supervision? So we'll kind of go around the world. Let's start with Cammie, then Minnie, and then Vicki.
Good morning. It's a very good question. You're always going to have resistance. There's always someone that doesn't want to go with a plan, and that's okay. The key, I think, and all of us will agree, is education. At the end of my program, I'm so sorry you couldn't see the slides. One of the most important outcomes for us is, yes, we have great outcomes for the patient. The patient is doing better, maybe a prolonged extubation, but they're doing better. The key is that the nursing satisfaction greatly improved, the RT satisfaction, and then you know what? We started with the top. The surgeons were happy. If your surgeon's happy, A lot of people are happy. The intensivist is happy. The APPs are happy. It is, the resistance has to be overcome with education, I think, and proving that they can't make a mistake. There's always somebody there to back them up. They have backup, they have protocols, plus there's somebody else there to help them. Vicki, do you want to add to that?
Yeah, absolutely. I always say the why. If you have resistance, and a lot of times, yeah, you do. If you can explain the why or show them the why behind it, it's hard to argue with that. It's hard to argue when you're focused on the patient, and if you're doing something that is going to be better for the patient, yeah, how do you resist against that? I've had some people say, you know, we've been doing this this way for 10 years and it's worked fine. My response is, you're in healthcare. You shouldn't be doing anything the same way for 10 years. There's always something new. There are, you know, you just have to look at the evidence and be able to share the why with staff.
I agree with both Vicki and Cami. That why for adult learners is essential of getting buy-in, finding that common goal, and really following through with the implementation and making sure it's well advertised what you're doing and why you're doing it. Because, you know, email is pretty much one of our main ways of communicating with staff, but it's not always the most effective. So making sure you're coming at them from multiple venues so that they really do have access to the information and the why for it as well.
I think that's great. I think, you know, sharing those celebrations is also really important, you know, looking at if your data gets better over time or, you know, if patients are able to get out of the hospital earlier. We're having a lot of questions asking about how you track your data outcomes. Jill had a great question talking about just how great it was to see the group of you guys up there empowering RNs and team-driven protocols across the US to really look at the data and to have an impact on patient outcomes. So the questions that come together talk about how do you follow your data within your own institution and make sure that what you're trying to do is actually successful.
So
Go ahead,
Cami.
Oh, I'm sorry, Vicki. I think what helped us the most is we have a STS coordinator. Actually, it's not a nurse practitioner, but it's a very nurse that's been in cardiac surgery for a long time, who works for the surgeons and actually collects that data for the STS protocol. That's very helpful because that tracks carefully. But what we did, Dr. Gelfand, what he did is he also enlisted you know, IT and statistics, one person from there who started looking at the data, and we hired another nurse during this 3-year period to collect data on extubation, early, late, outcomes with extubation, how many people had to be re-intubated, were there emergencies. So they actually allowed us to hire a separate person to help with the data, but we also use the STS person as well.
Yeah, same model. We have our STS individual. We look at that regularly, but we do collect the data on every one of our ERAS patients, and we have, I think now we've got 19 service lines. So, but I hired somebody, and she collects all of that data. We're going to have to hire somebody else because it's just getting to be too much for one person. But we do look at the patient outcomes. We look at MMEs, daily MMEs. We look at, like I said, the compliance, and we also look at discharge. Did the patient get a prescription? Did they fill the prescription? How many times did they fill the prescription? We really want to be able to track all of that. It's a lot of work. It's helpful if you have a dedicated person to it. We've got a full FTE just to do the data, and then I will run reports and do the analytics and report out the data.
We have a similar model at Nebraska Medicine as well. We have a whole department that's dedicated to the heart and vascular outcomes, and that's what my new department that I just joined is focused on doing. So we follow either, if the program has a registry, we'll collect data on that. Otherwise, we just follow certain outcomes that are strategically aligned with our physicians' goals, what opportunities that we have, and kind of target those. But we meet monthly with each service line to report out on our outcomes, and then do quarterly reviews with the upper leadership as well, to make sure that our strategic planning is on track with the overall organization.
Yeah. I'd like to just add one thing. I think that that's what we're all doing. And the most important thing is that we continue to monitor, so that like Vicki so wonderfully said, things evolve, they change, and you want to make sure that your outcomes are still coming out the same. So you have to continue all of this research, all of this follow-up. And we have M&M, morbidity and mortality, and we have to come up with good reasons why somebody did fall off that track.
So I'm going to launch our last poll now, and we can continue the discussion while people answer the questions. So what postoperative patient management strategies have been implemented in your unit? Let's see, post-op glycemic control, insulin infusion, pain management, postoperative delirium screening, postoperative persistent hypothermia prevention, chest tube patency management, chemical prophylaxis, prophylaxis and extubation strategies. I'll make a short comment that one thing that we are doing here at Methodist is actually patients recover in the same room. So it's a progressive care ICU where it's the same nurses who are the ICU nurses as well as the intermediate care and tele unit nurses, which has been really nice in the COVID era in particular. It requires less people to be in different rooms, including the environmental services. So that's one thing that I think has been very positive as well. What other things do you guys have that are unique at your institution that may not be listed in this poll?
Recently, we started a falls pilot where we're kind of looking at the risk factors to drive the interventions, as opposed to just kind of having like these blanket policies where we implement interventions on patients that might not make sense. So we're not going to put call lights or the fall alarms on patients who aren't confused, because they know to call out before they stand up. And we're seeing good data, and we're about to go live with that house-wide with our pilot. So that was an interesting thing that we just did.
Looks like almost everybody's using extubation strategies and post-op glycemic control.
There.
I'm not sure if you guys can see the polling outcomes, but I tried to share them. We'll be interested, you know, if there are other participants who have things that they are doing at their institution that may be unique. Please share those with us. I think it's very clear from this discussion and this panel that, you know, sharing our expertise across the nation certainly helps build other programs as well. We've got probably over 70 years of nursing, critical care, advanced practice degree experience between just the three of you alone. And you've certainly seen changes over time. So we just really appreciate the willingness to get out there and talk about what you're doing. We will definitely get you guys the slides. If you have questions, feel free to reach out either through CTSNet. I know each of us are able to be found on CTSNet, or through personal email. So we want to thank you for joining us for this discussion about optimizing resource utilization in the cardiac ICU. And again, a big thanks to our panelists. Thanks, everyone.
Thank you, everybody.
Thank you.